Hi everyone, and thank you for taking the time to joining us in a session today that is on the topic of advancing feeding and nutrition care for patients with cleft in Africa. So my name is Barbara Delage, and I'm pleased to welcome today three panelists, Mrs. Bertha Tendo and Mrs. Grace Nanyombe, who are two experienced clinical nutritionists working at Corso, a SMILE-trained partner hospital in Uganda, and the infamous Mrs. Feisara Debola, who is the project coordinator for grassroots SMILE initiative, NGO based in Kano, Nigeria. Today they'll share with us their understanding and experience on the importance and significance of nutrition in the provision of care to patients with cleft, the challenges they have faced or they are currently facing in the provision of nutrition care, any activities or innovations they have put in place or they would want to put in place to develop to improve nutrition care to patients, and they'll share with us some suggestions regarding the way forward to ensure that every patient can access the nutrition care they need. I'll take a few minutes before we hear from our panelists to say a few words about the central role of feeding, counseling, and nutrition care for patients with cleft from the time of birth. We all agree that the management of cleft requires a multidisciplinary approach. And here, I show you a timeline for the provision of healthcare services based on cleft care guidelines developed by the UK National Institute for Health and Care Excellence, called NICE. This timeline highlights the numerous medical and paramedical specialties that are necessary to not only repair the birth defect, but also ensure normal development of the child through proper feeding, normal development of hearing, speech and language, a good dentition, and the prevention or management of any psychological issues. So I'm asking rather naively, are there any official or national clinical guidelines like this anywhere in Africa? I'm asking because I think there is a need for a better overall guidance that is more suited to the context. I'm saying this because those guidelines, they do not consider context of high rates of malnutrition, high burden of infectious disease, or limited access to specialist healthcare. And I'm saying this again because when I look at this timeline, what I see is that the need for feeding assessment, education, and management is mentioned only for the period of birth, from birth to 8 months. Although we know that the context within which partners in Africa operate demand not only timely support from the time of birth, which is already problematic, but a closer follow-up well beyond 8 weeks, especially for children who will not be operated before age 2, for example, or who will require multiple operations. Next.
Would you please project your voice? You sound a little low. Thank you.
Sorry, I'll try. So next, I thought I would highlight a few documents that have been developed by SMILE-trained to support partners' efforts towards offering feeding support and nutrition care to mothers and patients. In particular, there is a document that I show you here called Guidance in Nutrition Care Provision that was developed to help support capacity building in nutrition. This document defines and describes 3 main components of nutrition care provision: feeding counseling, nutrition assessment, and nutrition care. And these documents describes the key actions associated with these 3 components, as well as the professional competencies required to undertake these activities to ensure that the most effective, appropriate, and safe care is provided to all patients who are managed by SMILE-trained partners. So we hope that this document can be of help for partners who want to audit their current activities, and especially human resources around the feeding and nutrition care provision to their patients with Cleft, as well as for partners who would want to start a nutrition program or strengthen their current activities. I believe many of you have already heard of the nutrition training curriculum that has been developed by SmileTrain together with the Spoon Foundation to improve partners' capacity to offer feeding and nutrition care to patients with Cleft. The training content is again aimed at supporting the building of capacity in Cleft teams by improving key knowledge and skills, in particular regarding the feeding counseling of mothers and their infants, and the best practices in terms of nutrition assessment, such that partners are well equipped to address feeding and nutrition challenges. The last thing I wanted to mention is the SmileTrain Nutrition Grant that is meant to help partners start a nutrition program or expand or strengthen their existing program. So all the nutrition related activities described in the guidance of nutrition care provision, the document I showed you a few slides back, can be potentially covered by a nutrition grant. The cost of activities and supplies meant to support the feeding and nutrition of patients with Cleft and their mothers can be potentially covered by a nutrition grant. This includes the cost of food items, feeding tools, hospitalization, some equipment, patients' transport, educational activities, etc. So this is my last slide. So what's needed to start with you is for you to have a clear idea of your needs and how you would plan to address those needs. If granted funding, you will be asked to write an end of the year summary to report on the activities undertaken, the successes, the challenges. If the activities that are funded are restricted to feeding counseling activities, you are unlikely to be asked to report any additional data on the STX platform. Anyway, the first step, if you have identified needs and would want to support activities to cover those needs, is to reach out to your regional SmileTrain staff who can better offer a guidance. Now, let's hear from our panelists.
Yeah, good morning and good afternoon. The topic of my lecture is Advancing Nutrition Care in Africa, Grassroots Smile Initiative Experience. Next slide, please. My outline is as follows. Introduction, importance and significance of nutrition in Cleft care, challenges experienced on nutrition care, innovations adopted to advance nutrition care in our organization, way forward in supporting Cleft patients access quality nutrition care, then conclusion. The next slide, please. Now, my name is Feyi Adebola. I'm the project coordinator, Grassroots Smile Initiative, Kano, Nigeria. Next. Grassroots Smile Initiative was funded in the year 2005. It is a non-profit, non-governmental organization. It was set up to advance the cause of cleft and oral health care delivery in Nigeria. Now, cleft lip and palate children have feeding challenges depending on the severity of their cleft. They therefore need good nutrition so that they can grow and have immunity to fight illnesses. Good nutrition also will also enable them to have good brain development. Normally, when children are about 2 years, 80 to 85% of their brain is developed. And by the time they are 5 years old, 95% of their brain is developed. So you can see that they need healthy, balanced diets. Good nutrition also prevents childhood obesity. So also, in the case of our cleft babies, it makes them to be fit for surgery. So also, they also need good nutrition so that they can heal fine. It also enables them to attain growth milestone. That is, they can roll over, crawling, walking, and talking at the right time when they are supposed to attain those milestones. Because if a child has cleft, the child can also grow and develop like other normal children if the child is properly fed and the right health care is given to the child. Lastly, most children are at the greatest risk of malnutrition from the age of about 6 months. When children are 6 months old, the breast milk, the baby formula that we give them is no longer enough. They need nutrients that they can get for solid so that they can grow and develop properly. The next slide. Now, the challenges that we experience in our organization. The first challenge is poverty. Most of our patients are from the rural area, and they are from very poor economic background. So having a child with cleft is an added burden for them. So they need help. So also, most of the mothers that come to our organization don't know anything about clefts. Their own knowledge about cleft is what they've been told in their community, when their baby is born. And it is very important that it is a cause that the child is evil. So it is very important first for us to address those misconceptions when they come. And so also they don't know anything about cleft feeding. Most of our babies are born at home, delivered by local birth attendants. And that was why we felt the need not too long ago to train local birth attendants so that they can know how to counsel those cleft mothers in the rural areas. So also there is also this fear of stigmatization by mothers. Once they have those children with cleft, they are ashamed. They hide them at home. And by the time they bring those children to us, the children are severely on their weight. So we have to start working on them. And then cleft is not funded by the government. So you see that these women cannot get help, even from the government. We have problem of insecurity now. Banditry, kidnapping, a lot of our people cannot go to their farms again, and a lot of villages display. So this is the condition that we are working in right now. The next slide. There are innovations adopted to advance nutrition care in our organization. In our organization now, we have a nutrition team made up of 2 pediatricians, 1 nutritionist, and 1 social worker that also acts as a counselor. Every patient that comes to our organization now, in their first visit, we counsel them so that we can give them the support and the encouragement that they need so that they can, having a child with clefts can be emotionally traumatic. They've come, some of them are shocked, they are confused. So we have to, as much as possible, reduce those confusion so that they can work with us. We have also developed training, capacities of our mothers and caregivers in areas such as, we have trained them in the importance of breast milk, how to express breast milk by hand. We've given them training on good hygiene, and so also on immunization, because most of them, when they come to our hospital, because of some things that have been told to them about immunization, they don't want their children to be immunized. So we try to talk to them about that. We've also developed training, for healthcare providers on nutrition education. So also on physical activities as well. And our organization, have also developed educational videos, sponsored by the Smile Train on infant dental health, on breast milk alternative, on local food supplements, and a host of other videos that we have now all sponsored by the Smile Train. We also, like I said, we have a nutrition team. We have our own now nutritional program. That is, every patient that comes to us now, their first visit, most especially the babies between 0 to 59 months, we do nutritional assessment for them. That is doing the anthropometric assessment, that is taking the weight, the length and the head circumference of those babies, so that we have a baseline, so that as they come for review, as they come, the baby come for immunization or the baby is sick, we take those measurements again, so that we know if those babies are developing normally, if they have any growth problem, if they have any trend of having growth problems. So we do that for every Cleft babies that come now. So also we do the clinical assessments and the biochemical assessment and the dietary assessment as well, so that we know how to progress with these children. Lastly, we have this women empowerment program. This women empowerment program is key to the success of our organization, because there is no point, putting these children on the Smile Train nutritional program when their parents don't have anything to eat. So there's every possibility that the baby formula, the syrup that you are giving them, is going to be used for their other children. So now that we have introduced this nutritional program, we see that they are taking care of our Cleft babies and everything is going fine with them. The next the next slide, please. Then way forward. Now, what is the way forward? If we want to, if we must move forward in a purposeful way, especially in the knowledge about nutritional, then we must sustain a good nutritional program, like I've just explained. So also we must develop capacity of care providers, most especially nurses, because in education, in nutritional education, because they are the ones that are with the patient 24/7. If we look at the number of nutritionists that we have, most like in Nigeria now, they are very low compared to our population. So it is very, very important that we start organizing training for nurses so that they can bridge that gap, and help our children with nutrition. So also this empowerment program for mothers, because most of our patients are from the rural areas. If we want this Cleft children to stay alive, we should also address the problem of the Cleft mothers. So also we should encourage local food supplements for both mothers and children. We have local formulated syrup that we give mothers that have low breast milk and those that have no breast milk at all. We also give to children that are about 6 months and above. Apart from that, we also educate mothers on local food that are affordable in their locality, that they can combine to give them a balanced diet. We give them education on that. Lastly, it is also very important that there should be advocacy for government support of Cleft care, so that we can, the government too can be involved to help take care of these children. The next slide, please. In conclusion, importance of adequate nutrition for Cleft babies cannot be overemphasized. So also there is need for good nutrition program, and we must also source for local food supplements that our Cleft mothers can take. Those that are malnourished, we have them a lot, and also these children that can also take from 6 months and above, so that there should be also advocacy for government support as well. And lastly, I would like to thank the Smile Train for their demonstration of love for all poor Cleft patients in Africa. They have continued to bridge that gap, and we are really grateful for what they are doing. Thank you very much.
As we've been introduced, this is Grace Mbata from Kosu Rehabilitation Hospital in Uganda. where we are clinical nutritionists, and we deal with children with cleft lip and palate together with other congenital abnormalities. So in today's presentation, we are actually going to take you through how we are going to be advancing the nutrition cleft care in Africa. Some of the things that we're going to talk about include the importance and significance of nutrition care the importance and significance of nutrition in cleft care, together with the challenges on the nutrition cleft care that are being faced in Uganda. And my colleague will as well take you through the innovations that have been adopted by the nutrition clinic here in Uganda, specifically Kosso Hospital, on how we are going to advance the nutrition cleft care. Next slide. Next slide. Okay. I'm going to take you through the importance of nutrition in the cleft care. Apparently, we very well know that children who are born with cleft lip and palate always present with feeding difficulties, whereby some of the feeding difficulties that they face, they may fail to actually latch on the breast milk. Some of them may actually fail to create a sanction for breastfeeding, and others may as well be presenting with nasal regurgitations. It has been documented that actually children with cleft lip and palate, it's usually that 25% of them present with feeding difficulties. Then the ones that present with cleft palate, it's actually approximated to 73% that have feeding difficulties. It's so much known that a third of the newborns with cleft lip and palate usually also present with feeding difficulties. And you will find that at least 32% of them will actually need to have NG tube being fixed in to ensure that they actually get enough or adequate feeding. So next slide. Whereby you actually see that the children with feeding difficulties usually present with consequences which will include increased feeding times, and as well the weight gain will actually be low, which will mean that they will always fail to thrive if there is no nutrition intervention that is being done. So the goal of nutrition care in children with cleft lip and palate is usually to ensure that at least if they are able to breastfeed, we initiate early breastfeeding as early as possible. Then we also ensure that if they are not able to breastfeed, we always come up with breastfeeding alternatives, which can include express breastfeeding or use of high energy milk, then as well the formulas. And this will actually ensure that they attain an adequate weight that is required for surgery. Then another goal is to ensure that these children usually always have a pre and post of weight gain or a good nutrition status, and as well good surgical outcomes. Then as well, another goal of nutrition care is to ensure that we prevent infections, as we very well know that if children actually have malnutrition, their risk of getting infections is always high. Another thing is that yes, they will actually have to achieve a very good milestone if the nutrition is actually good. Next slide, please. And now we are actually going to look at the challenges that we face here in Uganda in ensuring that we achieve a good nutrition, or in ensuring that we actually do an appropriate nutrition cleft care. One of the major challenges that we are facing here in Uganda is that nutrition cleft care in our facilities is not well rolled out, or it's not actually spread in other facilities, whereby you see that it's only Kosso in Uganda that is the center of excellence in providing nutrition cleft care. So it means that children or caretakers have to travel long distances so that they come and attend the nutrition clinics or the nutrition cleft care. Another challenge that we face is that we are currently not having a nutrition guideline, or we don't actually have nutrition policies that are specifically for children with cleft lip and palate, or that are specifically for children with craniofacial disabilities. So it means that most of the times these children are not catered for. Another challenge that we are facing is that we usually have challenges of household food insecurity and low economic status for children with disability, rather for children with cleft lip and palate. And this has actually increased the burden of malnutrition, whereby you find that most of the caretakers come from rural areas and they are not able to provide what is required of them to ensure that they continue with good nutrition at home. There is also a burden of disease and reoccurrence of infections in children with cleft lip and palate. They fail to attain a good weight that is required for the surgery at an appropriate time. Next slide, please. Another challenge that here in Uganda is that we really face a challenge of mothers not actually providing enough dietary diversity for the children because of their food insecurities and their low socio-economic state, whereby the challenge that is being faced is that they usually present with iron their nutrition status and as well poor surgical outcomes. You find that most of the children may have actually a good nutrition status in terms of weight, but if like their iron is actually low, or actually they have anemia, they will not undergo surgery. So that is actually one of the challenges, and it's really very, very crucial in cleft care. Then as well, there are children who present with other anomalies, especially those ones that are present with syndromes, on addition to cleft lip and palate. Basically, these children always fail to thrive, whereby we always struggle with them to attain an appropriate weight that is required for surgery. So it's really a challenge to us because you usually find that you do as much as you can, but due to their syndromes, it's kind of difficult to attain what is required. Then as well, we have limited access to modified and special feeding equipment that is required for children for feeding. Here in COSU, what we usually do is that if children fail to actually breastfeed, we always recommend other feeding equipment like special feeding bottles, lift cups, and as well other equipment. But it's not easy for them to be accessed here in Uganda, whereby most of the times we rely on donor-funded items, but at times it's difficult to actually get them. So it's actually a challenge to us. And so it actually affects the nutrition cleft care here in Uganda. Another thing that may not have been mentioned is actually the COVID-19 pandemic, which has actually left most of the children failing to thrive because first and foremost, there was an imposed lockdown, which actually stopped most of the patients from coming to access the nutrition cleft care. And as well, like most of the caretakers lost their jobs. So it means that there was actually a burden of them attaining a good nutrition status, or there was a burden of them actually attaining what is required of them. So COVID-19 has really affected the nutrition cleft care in Uganda, and it's still affecting. So those are some of the challenges that we are facing here in Uganda of actually providing the appropriate or what is required of us to prepare, or rather what is required of us to actually provide good nutrition cleft care here in Uganda. So my colleague is actually going to take us through the innovations that have been adopted here in COSU to see that we attain a good nutrition cleft care. Hello, Bertha.
Thank you very much, Grace. My name is Bertha, as I've been introduced earlier by the moderator. And I'm going to be talking about nutrition care in Uganda and the UNICEF guidelines. Our first line of care is always promotion of breastfeeding for these infants. But like Grace highlighted in the beginning of our presentation, that 73% of infants that have cleft lip and palate always face breastfeeding and feeding difficulties. So if we cannot achieve breastfeeding, we try alternatives, which can be modified breastfeeding positions. We also encourage the mothers to express their breast milk, especially in the early months of life. For this, I've had mothers, especially who are coming from rural areas, who have been able to sustain expressed breastfeeding using manual method, that is using their hands, up to around 4 months, which we believe has been a big achievement. And then one other innovation that we have come up with is that in Uganda, our population, most of the population of caregivers having cleft infants are unable to afford to purchase or to even use safely formula milk, commercial formula milks. So our unit came up with different high energy milk formulas that have various high energy with kilocalories starting from 75 kilocalories per 100 mils up to 100 kilocalories per 100 mils. These formulas have been very important in helping our infants to meet the increased energy demands feed, and they have helped the other innovations that we have come up with cleft feeding center. We have sought to partners in Train. Small Train has provided the funds to ensure that we have a constant supply of soft feeding bottles that really help these children that have feeding difficulties. With this special feeding equipment, the children overcome their feeding difficulties and the feeding experience is improved. Furthermore, our unit has gone ahead for the past 2 years to partner with the National Nutrition Unit to ensure that we get therapeutic feeds to help us in the inpatient and outpatient management of cleft infants and children that present with severe and moderate acute malnutrition. We have also gone ahead to develop nutrition information, education, and communication materials that are specifically suitable for infants with cleft lip and palate, and this has really helped the caregivers. With the onset of the COVID-19 pandemic and the lockdown measures, we realized that most of our caregivers lost their livelihoods, especially those that were not in agriculture. So we were able to come up with a program whereby for those children that were at risk of malnutrition, at risk of household food insecurity, we introduced nutrition take-home rations that actually bridged the scarcity or the gap that the parents faced in not being able to provide adequate nutritional foodstuffs for their children. Next slide, please. Next slide. That's the slide I'd gone through. I'm sorry. Next slide, please. So next slide, please. Yes. So I'm going to be talking about the way forward in supporting cleft patients access quality nutrition care. So here in Koso, at Koso Hospital, for the past 3 years, we noticed the need, like Grace mentioned earlier, that rural health workers are not conversant with how to manage cleft infants. And yet in most cases, they're the ones who come in first contact with these children. So we have sought to build capacity for the rural health workers by empowering them, plus also the mobilizers. We have done trainings for them basing on the Smile Train curriculum that was developed. And we have had some success stories where some children have been referred to us when they have been managed and they have a good nutrition status. Among the ways that Cleft access to Cleft to quality nutrition care can be advanced or can be supported is capacity building for the current nutrition Cleft specialists and also other health workers. And here we also believe that exchange visits or experiential visits could also be of help. It can broaden the knowledge base and also widen on the care practices. And with the onset of COVID-19, we believe that we need to adapt to telehealth innovations, for example, the use of phone calls, social media to conduct nutrition sessions and follow-ups, but this is ongoing. We also want to strengthen partnerships with organizations around Uganda supporting Cleft, and of course, hospitals and government institutions. We also development of a national platform that can coordinate Cleft activities within the country in a streamlined manner. This will improve access to quality care for Cleft infants. Thank you very much.
So thank you very much, Grace and Bertha. And again, thank you very much to Mrs. Adebola. We have a few questions or comments. So let me look at them. So one attendee asked, can Smile Train share your educational videos from Kano in English, please? Great talk. So my question is, so I understand that both Mrs. Adebola and also the coastal nutritionist have developed educational material to maybe explain to mothers the basics of how to feed their children, or maybe also for healthcare workers or all other health allies. So I want to know if those material that you have developed, you have shared it with Smile Train, and maybe anyone from Smile Train can say whether or not these are somewhere available to share between partners. Mrs. Adebola, maybe? Oh, you need to put your microphone on. Your microphone, Mrs. Adebola. Yeah.
Yeah, yes, we can share. They are all in English.
Okay, but you have not shared them yet.
We have not.
Okay, okay. And thank you very much. And what about Bertha and Grace?
From the coastal side, I think we've shared some of them, though there's some that we shall have to share.
Okay. Okay, so I don't know if someone from Smile Train, maybe NK or Nicole, can maybe tell us whether or not there is a place somewhere on STX maybe where partners can upload some material and this material can be shared between partners. No? No answer on that. Well, this is definitely something that we need to think about. There is a question in French from, oh, I'm sorry if I messed up with your name, Prudence Kumirarash Agenonga. She's a GP in Kinshasa, and she would want to know if she could benefit from the nutrition training from Smile Train. She is available to follow training in surgery to fix cleft. Okay, so I don't know about training as a surgeon, but the nutrition training is definitely something that you could benefit from. But when it comes to training in surgery, that I don't know, I'm pretty sure SMI train support the training of some surgeons. But again, I mean, I'm not the best person to answer this question. Anyone? Maybe
Okay,
Nicole?
Yes. Thank you, Barbara. Bonjour, docteur Prudence. Nous allons vous mettre en rapport avec notre collègue qui travaille en RDC. C'est Madame Deborah Zawadi. Elle, si vous pouvez lui envoyer votre adresse mail dans le chat room, elle vous contactera et vous montrera la voie à suivre. Merci.
Okay, so basically what Nicole said to Dr. Prudence is, you know, just to email Deborah, and she'll get all the information she asked for. There is another attendee saying, thank you for the presentation. Please, what is the composition of the nutrition rations given to the children with cleft, to the baby with cleft? So I think this is a question for Bertha and Grace. You've mentioned that you have put in place a system with food ration that you would give to children who are at risk of malnutrition, or maybe who are malnourished, and whose parents are suffering from food insecurity. Can you tell us what you put in this food ration that you give to these children? Grace?
Thank you very much, Barbara. This is Bertha using Grace's phone.
Yes. So go ahead.
So in the take-home rations, we include, so we separated them. There are those that are for children less than 6 months, and then those that are for children that are greater than 6 months. So for those that are less than 6 months, we usually do milk, homogenized milk, the sunseed oil or the vegetable oil, and sugar to enrich or to help them make the high energy milk preparations like we advise them to do, like we demonstrate to them on how to do that. And then for the children who are above 6 months, we give them the same package, but then we include a composite flour of maize and soya with fortified minerals. So since they have started wean, to help them bridge the gap or to close the gap of household food insecurity.
Okay, so I have an extra.
I don't know, is that clear?
Yes, but I have an extra question about this, what you call high energy milk. Are they like milk based on like cow milk, or this is what it is?
Yes, Barbara, it's based on cow's milk.
Okay.
So it's based on cow's milk. The milk preparation is based on cow's milk. So depending, we always get fresh cow's milk, then that is okay. If they are not able, if they have no access to fresh cow's milk, we then recommend the homogenized milk, the pasteurized and homogenized milk.
Okay. Okay, thank you very much.
Cow's milk.
Yes. Another question.
Cow's milk.
Another question to you, Grace and Bertha, because you mentioned that you would be using NG tube for feeding about 1 in 3 children with a cleft palate, which I also found it very high. So can you tell us in which circumstance you use this NG tube?
We didn't get you clear.
Okay.
Barbara, repeat the question.
Yeah, so I'm repeating. So there is a question about for feeding. You mentioned that about 1 in 3 children with cleft need the use of NG for feeding. Did you hear? Grace?
Yes.
Yes, you
Barbara, sorry, we are actually not getting you, but what I'm trying to get is that, yes, I mentioned that I mentioned that at least 23% of the children with cleft palate usually it's usually recommended that they actually have an NG tube. This is because that okay, children with the cleft palate usually actually fail to get an appropriate feeding equipment, if like especially they are not actually having the feeding equipment, and so you find that the oral feeding will usually be difficult. So it's recommended that as we attain or as actually we try to establish oral feeding, NG tube feeds usually come up as alternatives. So like we usually win them of the NG tube feeds as we establish the oral feeding.
Okay, that was not
That's
very.
it.
Is that clear?
No, that
It
wasn't.
wasn't clear.
Yeah, the sound was not very good. I mean, what I wanted to know is, do you use it for children maybe who were born prematurely or who are severely malnourished?
Yes.
Okay, but
So the issue is that actually we usually give them, we usually actually recommend that the ones who are severely malnourished, or the ones who are born prematurely, or the ones that actually have very low birth weight, ones that usually go through the NG-tube. That's usually actually beneficial for the NG-tube feeds. Though
okay.
still, if like yes, the child is not well, the oral feeding is not well established, however much they have an appropriate weight, the NG tube will actually serve as the line as we establish the oral feeding.
Okay. Okay. Well, thank you very much for your answer.
Yes.
There's no Nicole, you wanted to answer this question? Okay. So there's no more questions. Nicole, Emily.
We can't see any other questions on the chat, so I think we can close.
Okay, so I will thank again Mrs. Adebola for her time, for her insights, same to Grace and Bertha, and I'll give the floor back to either Emily or Nicole. And thank you very much to all the attendees today.
Great, thank you so much, Deborah, for Barbara, for such a great moderation. Thank you, Mrs. Adebola. Thank you, Grace and Bertha, for such patience in answering our questions and in being present for today's session. This was brought to you by the West African College of Surgeons in partnership with Smile Train. We look forward to having more interactions about cleft care and advancing cleft care, quality cleft care in Africa. I wish you a fantastic time until next week on Monday, same time, 11 a.m. West Africa time. Have a lovely, lovely day and month ahead.
Thank you. Bye-bye.
Thank you too.
For internet.
Thank